Hello, welcome to a Physionic detailed study analysis. Today we're going to be going over 5 studies to come to a conclusion on if inflammation has an effect on cardiovascular disease risk. If you'd like a shortened version of this video, because I realize it's going to be quite long, then simply skip to the conclusion section, the takeaway section, and you'll get a really high-level view of the overall conclusions. That said, however, you're going to be missing out on a ton of detail because we're going to be going over mechanisms, we're going to be going over data, we're going to be going over some scientific reviews, we're going to be going over a lot of information in this analysis. So if you're here to stick it out all the way and you're not familiar with who I am, my name is Nicholas Verhoeven. I'm a PhD candidate in molecular medicine. This is what I do. I take studies, I analyze them myself, then I put them out on an open format like this so you can look over the data for yourself and in an understandable fashion, and then either agree or disagree with my conclusions either way. If there are any additional amendments that come out after this video publishes, then check out the pinned comment, or I'll have some sort of highlighted section that's going to have amendment for anything that I end up missing and need to correct after the fact. Okay. With that, let's go ahead and jump into this. All right, so the main topics that we're going to be discussing are the mechanisms of inflammation on cardiovascular disease progression, as I mentioned at the beginning. Then we're going to be going over the Jupiter trial and the CANTOS trial. So both of those are really big studies that have been performed to try to determine if inflammation specifically has an effect on atherosclerosis risk. Now, if you're one of the insiders, the Physionic insiders, you'll also get access to the anti-inflammatory therapies that have been validated and shown to potentially work, as well as some unconventional blood markers. So we talk about specific conventional blood markers, while I'm going to be going over some unconventional ones that seem to also have some science behind them in terms of identifying cardiovascular disease risk. If you want access to the full version of this video that you're watching now, then just hop on over and join the Physionic Insiders, where you'll get access to this as well as all my other study analyses, as well as a written summary, a shortened summary of all the main points that I go over for all my study analyses, as well as seminars and a bunch of other good stuff, insider podcasts and a bunch of other stuff. So I won't go into it, but if you want to join, then there's links available for you. Okay, but let's go ahead and move on with the public content, and then I'll remind you about the insiders later on if you decide you want to continue. All right, so the mechanisms that have been proposed that are involved in cardiovascular disease, that's CVD here. So we're going to be gleaning this information from 3 different scientific reviews. I've labeled them 190, 191, and 192. There's a little bit of information on the funding sources. I'm going to have a notes section that's going to be in the description box. You can click on that, and then you'll find out more information on the public funding, or the funding in general, the actual funding sources themselves, as well as citations or references for each of the studies so that you can look up the studies for yourself. That said, so mixed funding means that some of the funding was publicly donated, so it may be like nonprofit or maybe government funding. On the other side, it can also be industry funding, a little bit of industry ties. Public funding is all government funding, and then study 192 is public funding, but there are some conflicts of interest as one of the researchers has a patent or some sort of association with atherosclerosis treatments of some sort. But again, more details are in the notes. All right, so let's discuss this. Let's discuss the beginning of how atherosclerosis occurs. Now, I'm going to be focused a lot more on the inflammation side. This is not going to be an all-encompassing review of how atherosclerosis progression starts or continues, but I'm going to be more focused on the actual inflammatory process that's been proposed. So here we've got a blood vessel, we've got red blood cells, and we've got lipoproteins. So in this case, we're talking about LDL molecules, but it could be, VLDL or IDL, doesn't matter. The point is that you have these lipoproteins that are circulating through the bloodstream. Now, if you have large amounts of these lipoproteins, then they start to get incorporated into what's known as a plaque buildup, or an atheroma, which starts to build up this plaque deposition in the wall, the actual vessel wall. And the reason why that occurs, I've covered this in other content, is because you have these proteins that are in the actual wall itself called proteoglycans. And these proteoglycans, I believe they are positively charged. Don't quote me on that. Either they're negatively charged or positively charged. Either way, they're the opposite charge of these proteins that are found on the lipoproteins. So the lipoproteins that contain cholesterol and triglycerides, but we typically associate them to cholesterol molecules, these kind of brownish proteins that are found on top of them are called ApoB. So these ApoB proteins are attracted to the proteins that are found in the vessel wall. These proteins are called proteoglycans. These proteoglycans are attracted to the ApoB, so they attach, and then they linger there attached to the vessel wall. Now, typically what happens is you get the release of those proteins over time. So if you have low levels of these lipoproteins, they'll attach and then they'll release. And the attachment and release rate is essentially in equilibrium. So you can get attachment and then release continuously, and you don't get the buildup of this plaque. However, if you have higher and higher levels of these lipoproteins, then you have more chances for these lipoproteins to attach, which means that the lipoproteins attach, they stick around, and then you have some still releasing, but you have more and more that are attaching at a faster rate. So as a result, you start to get this buildup of plaque. Okay, so that's the general understanding, but then there's a lot of things that end up progressing from that point onwards. So what actually happens? Well, here we're zooming in. So let me go back real quick. Here we've got our plaque buildup. And here we've got our plaque buildup zoomed in. We've got a red blood cell all the way out here. It's probably a lot smaller than that in reality, but just so you have some idea of what this looks like. We're zooming into the plaque. This is a little bit out, well, definitely significantly out of scope. But you have this plaque buildup with the LDL molecules or particles that are finding themselves in the actual plaque. Now, that occurs past what's known as the endothelial layer. So these cells right here, this top layer of cells, just this single line of cells are endothelial cells. I'm not going to go into their typical function or anything like that. Just know that we have one line of these endothelial cells, and they are part of the intima. And then we have another section of our vessel wall, which is made of what are known as smooth muscle cells. So you know muscle cells, these are a specific type of muscle cell known as a smooth muscle cell. And these actually allow for the vessel to contract, to become smaller, or to relax. And these smooth muscle cells are typically found in the media, which is a section under the intima. And however, as atherosclerosis progression continues, these smooth muscle cells are activated to essentially transmigrate. So they migrate closer to the endothelial cells. So they should be separated. They should be down here, but what they end up doing is moving up here on top of the plaque formation. And eventually what happens is that they end up releasing a bunch of different factors, but they also release what are known as ECM proteins, so extracellular matrix proteins. And the reason why they do that is because they're trying to create what's known as a fibrotic core, or fibrotic cap, I should say. A fibrotic cap where they're trying to keep this plaque from rupturing. And the only way that they can do that is by essentially creating a structure, a strong structure, like a lattice structure over this kind of squishy plaque. So they start to release all these extracellular matrix proteins, which are this lattice structure. So we're talking about like collagen, elastin, things of that nature. And so that's the fibrotic cap that gets forced on top of this plaque formation. However, before any of that actually happens, the actual plaque itself has significant effects on these cells. One, it actually, quote unquote, convinces these smooth muscle cells to migrate on top of the plaque. And the reason why it does that is because of the LDL molecule. So the LDL particles themselves have direct effects on the cells. So the cells can bind to these LDL particles And if they get bound by a bunch of them, then there are a number of different mechanisms that I'll show you a little bit in a little bit that end up changing the behavior of the cell. So the cell is in its quiescent state. It's perfectly healthy, doing everything it's supposed to be doing. And then if it interacts a ton of LDL, LDL is binding to the LDL receptors on these cells, and they're being taken up. The LDL particles are being taken up within the smooth muscle cells, within the endothelial cells, and within the inflammatory cells, which I'll get to in just a second. Then these smooth muscle cells change their behavior. Literally, their genetics, the gene expression, not the actual genes themselves, but the gene expression changes. So the profile changes from a anti-inflammatory quiescent state to a pro-inflammatory, pro-atherogenesis state. And one of the actions that they do is they start moving to cap this plaque. The other thing that they do is they start releasing this ECM. Another thing that they do is they start releasing cytokines, which are inflammatory molecules that attract, chemokines specifically, but cytokines in general, attract immune cells and will start to change the other cells in the environment to become more pro-inflammatory. So they're not just having an effect on inflammatory cells, they're also having an effect on the endothelial cells and other smooth muscle cells. Okay, so the other thing that happens when you have this mass release of cytokines is that these smooth muscle cells will undergo a process called dedifferentiation. Dedifferentiation means that the smooth muscle cells start to not recognize themselves as smooth muscle cells anymore. It's not like these cells are thinking about it. It's just the genetic profile ends up changing so that the smooth muscle cells become a lot more like inflammatory cells. So they start to change their what's called their phenotype, the way that they display themselves. So they become a lot more like immune cells. Okay, so these cytokines are being released. So we see some of these cytokines right here. And what ultimately ends up happening is you get the recruitment of monocytes. You get the recruitment of immune cells as a whole, but monocytes are the ones that are floating through the bloodstream. These monocytes will then transmigrate through the endothelial layer, as well as sometimes through the smooth muscle layer, but in early stages just through the endothelial layer, and will find themselves in this plaque. Now, why are they doing that? Well, it's actually to help clear out these LDL particles. They will actually end up latching onto these LDL particles and intake them, and then try to eliminate them. So the way that they eliminate them is by breaking this shell, the actual vessel itself, and try to deal with the cholesterol that's found within. Now, what happens is if this happens repeatedly and with a huge burden, which we definitely have a huge burden with the high levels of LDL, is that these immune cells become overwhelmed so that they're continuously trying to eliminate this LDL to try to pull them inside the cell instead of keeping them outside the cell where the plaque can continue to grow and grow. And the immune cell ends up turning into what's known as a foam cell. So these foam cells are these immune cells, and don't have to be immune cells, they can be smooth muscle cells as well, where these immune cells that eventually have so much cholesterol within them that they become dysfunctional, and they essentially get trapped in this region. So we get monocytes that move in, they'll get turned into macrophages, which is essentially they just decide to be more of a mature version of their immune self. And then these macrophages start taking up all the cholesterol. The cholesterol then becomes overwhelming, becomes a burden, and you get the formation of foam cells. The foam cells then further release more cytokines. So we already have cytokines released from endothelial cells. We already have cytokines released. Remember, those are pro-inflammatory molecules. Then we have more from the vasculature, the smooth muscle cells. And then we have some from the immune cells. So the next step, unfortunately, is that once the foam cells become so damaged, so just defunct because of the constant insult from the cholesterol, they end up going through necrosis, which is a type of cell death where you start getting the formation of necrotic cores. So the reason why this is problematic is because necrosis is usually considered an uncontrolled form of cell death. It's not planned by the cell. Apoptosis, which is a controlled form of cell death, is more acceptable for the body because the cell is undergoing its programmed system to destroy itself because it can't handle whatever it's being insulted with. So, and we're not talking about words of insult, we're talking about physical insults like actual damage that's occurring within the cell. So, in apoptosis, the cell will attract other immune cells, and then they will go through their normal programming of just getting rid of that cell debris. However, in necrosis, the cell is having damage or kind of pulling apart and dying without it going through its natural progression of programmed cell death. As a result, you get these debris pieces that are just free floating in this area called the necrotic core. Now, because that's the case, because it's non-programmed, other immune cells that come to that region become highly pro-inflammatory. So this is a strong signal to even further the pro-inflammatory situation within this plaque formation. So you have these pockets within the plaque that are highly pro-inflammatory, even beyond the cytokines, because these inflammatory cells get recruited to this area. Then they are trying to deal with the necrotic core as well as trying to deal with the LDL, and then they die. And then the process, you can see how the process continues to perpetuate itself. All right, so why does this occur? Well, let's look at this within the cell. So now we're looking within a single cell. We're looking at within a foam cell or within an immune cell. It doesn't really matter. Or a vascular cell. It doesn't matter. And what we get is the binding of a cytokine. So that's this. They look a little bit different in this diagram compared to this diagram, but they're the exact same. You have a cytokine receptor here. The cytokine binds to the receptor. This leads to the activation of a protein called IKK. And then IKK will phosphorylate or tag this complex known as NF-kappa beta, so NF-kappa B. So once this protein is phosphorylated by IKK, you have the separation of NF-kappa B. You have the nuclear factor, so the NF, that goes in one direction, and then you have the actual kappa beta, which is right here, which is the phosphorylated bit that ends up being degraded by what's known as the ubiquitin proteasome system. This protein then gets demolished, it gets destroyed. Okay, we don't really care about that right now, or really at all. What we care about is what happens to this section of the protein. This section of the protein called, again, a nuclear factor, so it's a series of proteins or a complex of proteins that will then end up moving into the nucleus. So here's the nucleus, here's all the cytosol. So this is the inside of the cell, but we're not talking about within the mitochondria, we're not talking about the endoplasmic reticulum, the Golgi apparatus, none of that stuff. What we're talking about is anything that's outside of the nucleus. Now, the NF will then move inside the nucleus where all of our genes are kept, or the majority of our genes are kept. And then there, the NF will bind to pro-inflammatory genes, a whole host of different pro-inflammatory genes, and encourage the reading of these pro-inflammatory genes. Well, guess what happens? What happens is you get the greater production by this cell to produce more cytokines, more chemokines. Chemokines are specific cytokines that attract the migration of immune cells. You get more cholesterol receptors that get put into the cell membrane, which means that more cholesterol can bind to these receptors, a little bit like this, and then can be taken up inside the immune cell. Now remember, the problem with that is that if you have so much cholesterol in the cell that it ends up dying. So that's hugely problematic. So the number of cholesterol receptors, if you have a ton of them and you have a ton of cholesterol in that region because they're within the plaque, then you're getting an even faster damaging and death of this particular cell. And then the other thing it does is because there's so much harm occurring, so much stress that's occurring within the cell, you have cell death proteins that also get produced, like caspases, for example. I'll give you an example of what that looks like in just a bit. But this is the canonical, this is what's known as the it's a very common pro-inflammatory pathway that occurs within the cells. Okay, so what actually has an effect. So if we were to pull out of this cell and look at just a single cell, but we're outside of the cell, we've got our macrophage here. We've got chemokines and cytokines that bind, which leads to this whole process right here. We have oxidized LDL as well as, well, I'll start with oxidized LDL. So oxidized LDL has specific receptors that can bind, or the macrophages or the cells in general have specific receptors called LOX1 receptors that can then bind specifically to oxidized LDL. So they have a specific affinity for oxidized LDL. So the more oxidation of LDL that you have, the more oxidized LDL that you have, or damaged LDL that you have, then the more of this activation that occurs. And you have this oxidized LDL also leads to this whole NF-kappa B pathway to occur. And then people think that things are just based off of oxidized LDL, and oxidized LDL certainly is extremely damaging. However, there's also bound cholesterol esters. So what the confusion between LDL and lipoproteins as a whole and these bound cholesterol esters is that people think, for example, when you're talking about cholesterol that's found in the bloodstream, so let's go back to our very first image, a lot of people call this cholesterol. And it's not entirely wrong. Technically, the lipoprotein is the vessel, and the cholesterol is found within that vessel. So that's why we relate cholesterol, we just say cholesterol as a whole, even though technically what we're talking about is the lipoprotein itself that contains cholesterol. Well, the cholesterol that it contains is cholesterol esters. So it's the actual cholesterol molecule as opposed to the cholesterol containing lipoprotein. They're quite different, but very tightly related. Now, we have other cholesterol containing vessels that are not necessarily oxidized. They can be like the large cholesterol, or they can be VLDL, or whatever it might be. And they contain larger amounts of these bound cholesterol esters, so these molecules that are bound together. Now, when they're bound, what happens is that they can form crystals. These crystals can be taken up within macrophages and do inordinate amounts of damage within the macrophage. Ultimately leads to more chemokine release, and eventually this macrophage will turn into a foam cell, and that foam cell will eventually die and become part of the necrotic core. So there's a lot of different mechanisms. I'm describing several of them, but to be frank with you, this is just scratching the surface. Even though we're getting in some pretty serious detail here, there's a lot more that actually happens. So another example of some other things that happen are these other immune cells. So we've been focused on monocytes and macrophages, but in reality, there's a lot of other immune cells that get involved in this process as well, including something from the adaptive immune system like T cells. So T cells are part of our immune system that reacts to a specific problem. So they're not just generally just circulating around. They get upregulated only when we have an infection, or only when we have a virus, or only, for a specific problem. And T cells can be involved in this whole process, although I don't have any images of it. But another one that's also important is the neutrophil. So the neutrophil is what's known as a granulocyte, meaning that it's within the neutrophil, there are these granules of essentially poisonous substances that get released when the neutrophil is activated and turns into a pro-inflammatory state. So these granules, which you see, them inside and you see them outside, when the neutrophil goes through a process called degranulation, it releases these poisonous substances to damage whatever's around it. And typically the neutrophil isn't doing this just randomly. It's doing it specifically when you're infected by a bacterium, for example, in which case it will degranulate and essentially decompose that bacterium. So it has a purpose. It's not doing it willy-nilly. However, in atherosclerosis, because there's so much going on, there's so many different insults going on, it can trigger not only the activation of the macrophages, it can also activate the neutrophils. Now, these neutrophils do a wickedly cool thing in that they send out these tentacles of DNA, these histones. I'm not going to go into too much on DNA biology, but your DNA is wrapped up around these protein complexes called nucleosomes. These nucleosomes are made up of histones. They're proteins. So think of think of it like a garbage can. It looks a little bit like a garbage can, and then the DNA is spooled around it. An even better example of that would be like in photography. You have these camera rolls. So the actual roll itself is the nucleosome, and then you have the actual film around that roll. That's the DNA. That's a perfect illustration of what we're talking about here. So you have these tentacles of DNA that get thrown out by these neutrophils, called the neutrophil extracellular trap, or net. And when they bind, or they physically interact with the macrophages go wild. They become extremely pro-inflammatory. So this is also a factor that has an effect on the macrophages specifically. And one of the ways that it does that is not just through, let me go back here real quick, not just through the activation of the NF-kappa B pathway, but also through the activation of what's known as the inflammasome. The inflammasome is a complex protein that essentially takes, it's more complex than what I'm showing here, but it takes what's known as a procaspase, or an immature caspase, which is a protein that ultimately does damage within the cell. This procaspase interacts with the inflammasome in one way or another and gets turned into a mature caspase. Now, what caspase does, if I can go back here, caspases will come in and start cutting up all the different proteins that are found within the cell. So this is a strong cell death signal. So if you have tons of caspases found inside the cell, you're doing massive amounts of damage within the cell. Now, this is a programmed cell death. This is the cell essentially giving up and saying, we have way too much damage. We will never be able to recover from this. Let's just go all in and just eliminate ourselves so that we're not causing more harm to the overall system, which is, the system is you. So it's doing this for your own benefit. It's killing itself for your own benefit. How noble of it. So these caspases will come in and destroy all the proteins within the cell: mitochondria, endoplasmic reticulum, peroxisomes, catalase, everything, absolutely everything. Just start cutting it up, just start destroying it. As well as you'll have some what are known as DNases, which will enter the nucleus and start cutting up the genes for irreversible damage, which ultimately leads to the death of the macrophage, or death of the cell. So this is an extremely potent mechanism by which the inflammatory system has further effects on the inflammatory system. And then to look at this, the neutrophil can come in and has this action not only on the macrophages, but can also have an effect on the smooth muscle cells and the endothelial cells. So it can actually puncture these cells and cause significant damage to these cells. So, and of course, this all progresses and progresses until eventually the fibrotic core, if you have too much damage of these smooth muscle cells, or if you have a thinning of the fibrotic cap, I should say, I said core, but again, it should be a cap, which is this extracellular matrix, which is not really shown here, but the extracellular matrix that caps on top of the plaque to keep it localized to one area. Well, if that thins because you have these cells that are continuously dying, then it can break and you get what's known as a thrombus, which ultimately causes massive damage downstream, but we're not getting into that. The point is just to focus specifically on the cytokines and the inflammatory process as a whole. Now, again, this is not even describing everything. This is describing a few of the elements, some crucial elements that have to occur, or supposedly that these are the mechanisms that have been implicated in the inflammatory process's role in plaque formation and atherogenesis. Now, you have to think, with all these different mechanisms and all these different ways that our body can be affected by inflammation, wouldn't it be nice to actually know how to prevent, or to actually see things coming before they actually happen to you? Well, that's what I cover with the Physionic Insider. So I'm going to go over cautions of reducing inflammation too much, preventing like different prevention markers to test for with a regular blood test, multiple therapies for reducing inflammation in the body, as well as you'll get access to a summary, so a written summary, so that you don't have to go through every single one of these study analyses. I have written summaries for all of my study analyses, hitting the most applicable points, as well as access to the Insider podcast, which releases once a month and aggregates all the data for you and then puts together all the application for you, as well as gives you areas where you can learn more on those topics. So that plus seminars and a bunch of other things as well. So all of that is covered in the Physionic Insider. So I would strongly recommend that you join the Insiders, and you'll get access to the absolute bee's knees premium content. And you can find the link attached to this content. With that, let's jump back into it. All right, now we've gone over the mechanisms that when it comes to inflammation on cardiovascular disease, and there's plenty more mechanisms, but I went over some of the most potent mechanisms. Now let's actually go over the evidence. Let's actually go over the data. So there aren't a whole lot of studies on this topic, but there are a few, and they're pretty robust. So this one is, this particular study did involve industry funding, and it's study 195, or 194, I should say. If you're interested in understanding more about the industry funding, where it came from, and have references and whatnot, just check out the notes that I'll have attached to this. They recruited 17,800 men and women, 66 years of age, that were overweight and had lower LDL-C, so that's the cholesterol esters that are found within the lipoproteins that we talked about earlier, and they had high C-reactive protein, which is an inflammatory marker. It was randomized, it was placebo-controlled, and it was double-blind. We've got a placebo group here, we've got a statin group here, and then we've got 5 years of treatment. And it was parallel design, so they're comparing the placebo versus the statin over the 5 years. Now, allow me to quick say that I realize that we're going to be discussing statins here, which is a topic that a lot of people feel very strongly about. That's completely fair, and I respect your opinion when it comes to statin. However, please don't insult me. Please don't attack the analysis without any sort of scientific merit. You should be looking at the data and trying to tease out if it's good data based off of what the researchers did. This is not, in total, this analysis specifically is more about inflammation than it is specifically about statins. I think the researchers here are using statins specifically because it has an effect on the inflammatory process as well. And that's why they're looking at people that already have lower LDL levels to see if the statin could have an effect on the inflammatory process directly and thereby have an effect on atherosclerosis risk. Again, if you'd like to reference other studies, that's perfectly fine and whatnot. Just be respectful. I put a lot of work into this, and I haven't made up my mind about statins simply because I haven't looked at enough research on statins. Just because I'm covering one study on statins doesn't mean that now I believe 100% everything about statins, but I put a lot of work into this. I have a pretty good idea what I'm doing. I spend my life studying this stuff. So again, if you're rude in any way in the comments, I'm straight up banning you. It's as clear as that. However, that said, if you disagree, you're 100% welcome to disagree. Just try to take the data that I'm presenting or have some sort of flaw in the methodology or something like that, and I will be happy to engage with you as long as I see your comment. Okay, just wanted to add that disclaimer because truly people get very, very angry when discussing statins. Okay, so let's look at the baseline values here. So like I mentioned, the age was 66. They split them up specifically 8,000, almost 8,900 in the statin condition. So that's this rosuvastatin condition versus the placebo condition. 66 years of age, exactly the same. They had roughly almost 40% women in each condition, maybe a little bit less. And then you can see some of the other metrics here as well. So like I mentioned, a body mass index, which isn't a perfect measure, but it's good enough for the average individual. They see that these people are slightly overweight. They did have slightly elevated blood pressure as well. They didn't have any differences in smokers, so they had 1,400 smokers, so about 16% in both conditions. So that cannot be one of the values down the line for the reason why there is some sort of results difference, because they're the same at the beginning. Family history, roughly the same. Again, all these things are roughly the same, but the crucial aspects is that high sensitivity C-reactive protein was high in both conditions. So these are people that have high levels of these inflammatory markers, but have relatively low, it's not the lowest, but it's relatively lower LDL cholesterol. So that's the key thing that they're trying to get across here. Looking a little bit more at the baseline values, triglycerides were exactly the same across conditions. Total cholesterol was almost exactly the same. So we're looking at really that both have that elevated C-reactive protein. All right, here we're looking at primary endpoints, which is major cardiovascular events, just in total, looking at myocardial infarction, heart attacks, stroke, peripheral artery disease, like all kinds of different things like that. Those are all grouped together into this primary endpoints. Then they've got myocardial infarction, stroke, or death from cardiovascular causes. So that's a little bit more focused than the primary endpoints as a total. Then revascularization or hospitalization from unstable angina. Angina is the pain that you feel in the chest, and death from any cause whatsoever was also quantified here. So here they've got two different graphs for this. So they're looking, so the higher the line goes, then the higher the risk for that particular group. Now they're showing it in an overall sense to show you the extended version, so over the 5 years, and then they've got a squeezed in version so that you can actually tell the difference between the two. So they're reporting both of them. Now here we've got the placebo group and here we've got the statin group. In all conditions, I can just go ahead and tell you, in all conditions, the statin group did better than the placebo group. And that's because the statin group is lower, so the risk is lower than for the placebo group in each one of these conditions. It's not quite as pronounced in the death by any cause, but when it comes to cardiovascular disease risk, there seems to be a more definitive difference between the statin and placebo. Then to look at the numbers specifically, so instead of looking at the lines and looking at the numbers themselves, they're comparing, again, the placebo group versus the statin condition. Here we've got the actual hazard ratio, so the actual risk profile between each condition. And here we've got our p-value. Typically, p-value cutoffs are 0.05. When you're talking about massive data sets like this, talking tens of thousands of people, then usually the p-value is going to be really, really low to show extreme levels of certainty. And they're reporting things as the rate per 100 person years. So if you see anything below 1, that would be typically a reduced rate of this primary endpoint, which, as I mentioned, is major cardiovascular events or non-fatal myocardial infarction, et cetera, et cetera. And then any situation where we're looking at anything above 1.0, then you see an increased risk. And then they're comparing this risk versus this risk to end up coming out with the hazard ratio itself. And what they find is that if we look over here, it's almost statistically significant across the board. So except for hospitalization for unstable angina, which approaches statistical significance, but it doesn't actually end up reaching that. So what we see is that for primary endpoints, which again is the main one, which is a combination of all of them, or most of them, then we see an increased risk for the placebo condition. We see a reduced risk for the statin condition. We also see a reduced risk for most of these other conditions, even in the placebo condition, but the reduced risk is even further in the statin conditions. And then when we look at the death on known dates, so my understanding of this based off of what the researchers wrote is that they knew around when the person was supposed to pass away. I assume that they had some sort of illness where the doctors could project exactly how long they were going to end up living, like a prognosis of, 3 months or 6 months or whatever. And then any deaths, so total deaths. And they see that there's an slightly increased risk with the placebo, and there's roughly no effect with the statin group. And I'm going to be able to show you exactly why that's the case in just a little bit. Now, here's the point where people would then end up screaming about relative risk and absolute risk. Obviously, here we're talking about relative risk, which is just the way that I explain it as a whole is that relative risk, it's not, I'm sure some epidemiologists could probably explain it better than I can at this point, but relative risk would be the way I would look at it is the difference in risk in that moment. So in this singular moment, based off of the data that they have, this is the overall reduction in risk. So in certain instances, it might be 30%, or it might be 50%, or it might be 70%. And then people will then push back and say, well, we should be looking at the absolute risk. Totally fair, 100%. However, then absolute risk is a much, much smaller number. And the reason for that is because, or at least the way that I interpret it, is that absolute risk is an over time measure. So the absolute risk calculation is going to be based on the data that you have up to that point. However, then you have to consider what would happen if you were to extrapolate that over 5 more years, 10 more years, 15 more years. Over time, decades of time, that absolute risk increases and increases and increases. The delta between the placebo and, let's say, the statin group or some other group, if you feel really badly about statins, just pick anything else. Low carb diets, veganism, doesn't matter. The point is that you have placebo versus the intervention, and the intervention starts to pull away more and more over time as people are on that intervention for 20 years or 30 years or 40 years. The absolute risk difference increases more and more. So it's inaccurate to then to push back on relative risk and then say, well, okay, what's the absolute risk? I'm going to tell you the absolute risk in just a minute. It's inaccurate to say, well, what's the absolute risk? See, it's only 0.3%. No way am I going to take this intervention, let's say like a vegan diet, whatever, if I'm only going to get a 0.3% improvement in risk. Well, that's because you're looking at the 0.3% improvement within a short time window. But if that continues to increase, think about a great analogy of this is like the stock market. If you put in money, or if you put in the risk is at this moment, and you increase over time, let's say 10, 20, 30, 40 years down the road, that compounds. It continues to grow. The protective effect continues to grow and grow and grow. And that's how you should be thinking about absolute risk, with that it gives you a snapshot in time, but it grows over time. With relative risk, it's giving you a snapshot in time relative to the control, in this situation, the placebo group. Hopefully I'm doing some justice to explaining this. I think it's a nuanced conversation. I need to create content on exactly how to think about absolute risk and relative risk. But I think about relative as in the moment. I think about absolute risk as in the moment, but you should also consider the overall, what's going to happen over decades of time. So what's going to happen down the road. Now, of course, a study like this, you can't do a randomized controlled trial that's going to last 30 years. It just doesn't happen. It becomes far more epidemiological than people want to admit. The level of control that you have to have in situations like that is just, it's virtually impossible, at least at this point. Okay, so I calculate so I've got the absolute risk specifically for the primary endpoint because that's what they were most interested in. So the absolute risk based on the primary endpoint was 2.8% risk for the placebo and 1.5% risk for the statin condition. So the difference between the two is 1.3%. Now that is way, way lower than like a like a 60% difference between the two conditions. The relative risk difference would be something, let's say like, well, here we've got it. So like, 56% or around 50%. But the endpoints, the absolute risk difference is way different. It's only 1.3% difference between the two conditions. So of course, again, people will look at that and be like, well, then I'm not going to bother with it. The point is that, okay, actually a great illustration of this is right here. So here, this is the one that we ended up looking at. So for the primary endpoint, we see that right here, let's say the difference would be like 0.1% difference. You're thinking, nah, no way I'm doing that. Like, it's worthless. Once you get to 2 years, maybe it's like 0.3%. And then it gets up to 3 years, it's like 0.9%. And then it goes up to 4 years, it's like 1.2%. And it just continues to climb. But that delta, you can see that the lines start to diverge. Now imagine if it's 20 years down the line, 30 years down the line. Now that absolute risk difference increases to 5, 6, 10% difference. Now we're getting into a category where you can actually consider what's the risk versus reward and actually get a sense. Now, this is not to discuss, that doesn't mean that there aren't, in this situation, potential negative effects of statins. If you take statins and you have a horrible experience with statins, then clearly no matter what the absolute risk reduction is, it's not going to matter to you because you have such a horrible experience with statins. However, for a person who does not have tremendous negative physiological effects from statin use, that's how you should be thinking about it. Then the risk calculation is a lot more in-depth than just looking at, in this one moment, what's the absolute risk reduction. Hopefully I'm explaining that correctly. I'm sure I'll still get plenty of pushback from people, but that's life. Okay, so then the next step, what they did is they did a subgroup analysis. So they wanted to separate out, do we see an interaction effect, which is right here, this interaction effect? Do we see a difference if it's by males or by females? If we separate the data by males or by females, or by people over the age of 65 or over the age of 65 or less than 65 years of age, smoker or non-smoker, et cetera, all the way down. You can see all these different measures. And what they found is that there's no interaction effect, except it starts to approach statistical significance when you're talking about family history of coronary heart disease. So if you're talking about like cardiovascular disease, a specific type of cardiovascular disease, in which case there seems to be potentially more of an effect, more of a protective effect when people did have a family history of cardiovascular disease. Now, that's really tough to tease out though. So as it stands, the interpretation here is that while they're breaking up all this data, and that's all great and whatnot, the overall effect is that there's no difference between the two groups. So that the overall benefit is just widespread across the board, as opposed to, like, let's say if you had smokers saw a benefit, but non-smokers didn't see a benefit whatsoever, then it would show statistical significant difference between them. And then you'd be able to determine, oh, maybe there's an effect that's only for smokers, and we shouldn't worry about that much for treating people that don't smoke. But that is not the case. That's not what we find here. And then looking at adverse effects, so I wanted to report on this, especially when people talk about statins. There's a lot of different adverse effects. So for adverse effects, this is looking at all adverse effects, any serious adverse effects. They have a predetermined definition for that, and then they just list them, however many people are in this condition. So they're comparing, again, the placebo versus the statin condition. Muscular weakness is something that's been known to typically happen more with statins versus certainly more than a placebo. And technically it's not statistically significant, but maybe there's a slight increase. It doesn't seem to be anything major. Myopathy, muscle disease, muscle damage, muscle injury, and then a bunch of other ones as well. Now, the only one that actually changes is death from cancer, and it seems like the statin condition actually had lower levels of death from cancer versus the placebo. Now, there may be something going on there that we're not aware of. Who knows? Another one that changed actually is also glomerular filtration rate. That is such a difficult word for me to say every single time. GFR, which is a measure of your kidney health. And we see that, the median comparison here is that there's a slightly worse in the placebo. We're talking about a 0.2 difference. So yeah, when you think about the actual effect size, that's minuscule. Glycated hemoglobin. So this is interesting, and this is also something that's often brought up with statins. Again, I need to look in the statin literature far more than I have up to this point, but as it stands, glycated hemoglobin, there was a statistical significance, and it was lower in the placebos, which might indicate that the statin condition, based on the little bit of reading I've done up to this point, is that statins could increase the risk of diabetes. I haven't confirmed that. I need to look into it specifically, but again, the effect size is pretty small, but it's still statistically significant. So you see a 0.1 increase or 0.1 higher level in the statin condition compared to the placebo. And then newly diagnosed diabetes. Perfect, right here, a great example. We got 270 versus 216, and it's statistically significant. So the statin group did have the negative of having more people with diagnosed diabetes. Now, keep in mind, this is 270 out of almost 9,000 people. Not nothing, certainly not nothing, and something to be aware of, but it's still a significant minority of individuals. And then I wanted to quick mention this, because this is the measures over time. So 12 months, 2 years, 3 years, 4 years. And remember, the study ended up lasting for 5 years, but they ended up having measures for up to the 4-year mark. And they're looking at the C-reactive protein levels, LDL cholesterol, HDL cholesterol, and triglyceride levels. Now, this is very important, mainly because it introduces a massive confounding variable. The reason why I say that is because the median levels at the baseline, remember, if we go back to the baseline here, the C-reactive proteins were 4.2 and 4.3. Here, we're looking at a drop, which is exactly what they wanted. They wanted a drop in the statin condition. They see maybe a slight drop in the placebo condition, but it's certainly much lower in the statin condition. And that seems to be consistent across the board. At 4 months, it's even lower in the statin condition, although it's also a little bit lower in the placebo condition. So we really see that difference. But the problem is that here, if I go back to the baseline values for the LDL cholesterol, it's about 108 at baseline. And here they're looking at a huge drop, like half of the LDL cholesterol in the statin group, which of course is to be expected because that's the primary outcome of statins. So the problem with that is that now we're talking about two different factors have changed. C-reactive protein, or the inflammatory marker, plus the LDL cholesterol. So now we have no idea which one actually caused these improvements, these relative risk improvements in cardiovascular disease outcomes. So this is a major flaw of the study. And unfortunately, we cannot base any strong conclusions simply based on this one massive confounding variable. Now, the placebo group did not see a change in LDL cholesterol, so they continued to have the regular LDL, but cutting LDL in half is a significant effect. Now, there were no differences, no dramatic differences in HDL, maybe a slight difference in triglycerides, but nothing too major there either. All right, so there was this huge confounding variable in the previous study, study 194. However, what researchers did is that they controlled for that confounding variable in this really pretty new study called the CANTOS trial. So in the CANTOS trial, they're looking at specifically an anti-inflammatory therapy as opposed to a statin therapy, which would also have an effect on LDL levels. And it is industry funding again. So again, more details for that are in the notes. In this one, they had 10,000 men and women, 61 years of age, overweight, with a history of heart attacks, and they had high C-reactive protein levels. They were put on this anti-inflammatory at a high dose, moderate dose, or low dose, or placebo. It was a 4-year treatment as opposed to the other study, which was 5 years, and it's again a parallel design. So to look at the baseline values here, we got our placebo group, again, 61 years of age, roughly across the board, low dose of the anti-inflammatory, the moderate dose and high dose. And you can just read through these, just look for any like major differences, but there aren't any huge ones. One thing I will point out is that there are no differences across the board for the LDL, which is really important, and no major differences for the total cholesterol, but really the LDL is the one that I'm most focused on. So, and what they also show is the CRP levels are roughly the same. Again, we're getting some high CRP levels, and we've got another measure of inflammation called interleukin 6, so 2.6, 2.5, 2.56, 2.59. These are all the same, which is great to see because we're seeing, again, we're setting ourselves up with a great baseline where there are no differences. Now, the key is to not have any differences at the end of the study, which was one of the major shortcoming of the previous study. Okay, so here, this is exactly the data that we needed to see. So we've got our low condition, our moderate condition, and the high condition. We've got a placebo. So the placebo, remember, they're starting out at 0, and this is over time, over the 4 years. They're starting out at 0. Anything negative means that there's obviously a drop. Now, the placebo is the blue line here across the board for all these conditions. And we're looking at C-reactive protein. We see a slight drop, a small drop in the percentage of C-reactive protein with the placebo condition. However, across the board, we see major drops, almost 50% or more drops in C-reactive protein with the low, moderate, or high, especially with the moderate and high concentrations of these anti-inflammatory drugs. And what is absolutely crucial is that LDL cholesterol does not change the entire way. HDL does not change. Triglycerides does not change. This is excellent, excellent. So that means that the only difference, presumably based on these metrics, and if we see any sort of positive effect, is due to the drop in the inflammatory markers specifically. That's huge. Okay, to look at the results here, we've got a placebo group right here. The primary endpoint is, again, cardiovascular, like overall cardiovascular events, so kind of a combination of a number of things. The severe cardiovascular events is what they have. And then they have it broken up across like a bunch of different ones, like stroke, cardiovascular death, specifically non-cardiovascular death, death from any cause. Like they got a bunch of different breakdowns, just like they did with the other study. I'm not going to go through every single one of them, but you can look at the data for yourself. And again, the p-value cutoff is 0.05, so anything below that would be statistically significant. And what they show is here they've got the hazard ratio clamped for the placebo. So the placebo is the 1, it's the standard. And then they're seeing anything below 1 for any of these conditions would indicate that there is an improvement or a reduced risk. Anything above 1 would indicate that there's an increased risk. Now, of course, you also have the statistical test there to determine if that's actually statistically significant. And another thing to keep in mind is that they've got a p-value here to determine just do any of the doses differ from the placebo, and then they've got one for each, a p-value for each dose to determine if there's a statistical significance versus the placebo. So this is just, is there an effect? And this one is more specifically which one has an effect. And it's important to note this because the low condition for most of these, except for this one, and it looks like close for this one. Yeah, I think just those two. The low condition was not better than the placebo for the most part. However, the moderate and high conditions were statistically significant for almost all, except for this condition and this condition and this condition. Basically these 4 conditions, but these conditions up here, like heart attack, stroke, and death combined, then you start to see a statistical significance between the different conditions. And then when you group all of them together, you have a few more that end up being statistically significant. Now, the reason for that is because they have greater power in the analysis, because they have all the subjects, all the participants grouped together. So all the ones that from low, moderate, high are all grouped together versus placebo. That gives you more statistical power in your analysis. So the conclusion from this is that it does so just reducing the inflammatory marker, C-reactive protein, in this situation has significant enough effects that it improves cardiovascular outcomes, but it doesn't improve every cardiovascular outcome. So some of these, if you were to, like, for example, just look at stroke, it doesn't seem like it has an effect. Now, that could be because they don't have enough participants, but ultimately that still probably implies that the effect is really, really mild. So it only has an effect on certain cardiovascular disease outcome. And I did calculate the absolute risk for, again, the primary endpoint. And the difference between the placebo and all of these conditions is roughly around 1% absolute difference. Again, just keep in mind what I mentioned about the time factor, where, absolute risk is very much constrained by time. Absolute risk tends to increase, or the delta in absolute risk increases with time, which we simply can't do a 30-year study. So this is what we have. It's a 1% at this time. But again, remember this whole compounding effect idea that I presented in the last study. Okay, and then again to report on the adverse effects. So looking at the adverse effects, most of them are roughly the same across the board. However, for example, arthritis and osteoarthritis and whatnot seem to be slightly improved by the anti-inflammatory effects, which makes a lot of sense considering osteoarthritis and arthritis and gout are strongly associated to and related to inflammation. But the effect sizes are really, really small. So it's not like massive, massive differences. But then, of course, that depends on the number of people that actually have arthritis. The other one that is actually concerning for a really small minority of people is that the number of fatal infections and sepsis, which is essentially rampant infection across the body, is increased with all of the anti-inflammatory effects. Now, the reason for that is postulated that because if you're dramatically dropping the inflammatory profile, then that actually hampers the immune system from being able to attack any sort of bacterial infection or viral infection. So it makes people more susceptible to death through infection, even if it protects over time with cardiovascular disease or some cardiovascular disease outcomes. Now, the effect size, again, here is really, really small. So let's say it's about double, especially with the high condition, the risk is about double. Again, here we're talking about relative risk, obviously. So we're seeing, let's say, a 40 to 50% increase in risk. However, the actual number of people that ended up passing away were 29 from thousands of individuals. So it's really, really specific to a small group of people. Those people have to be exposed to some sort of infection that ultimately causes this. However, of course, that number would grow as longer time of exposure. Again, the same concept as the absolute risk. You would see an increased risk as that continues to grow over time. However, the risk would still be quite small because you're seeing such a small effect here. So the midpoint conclusion and takeaways is that inflammation is likely a factor in cardiovascular disease progression. Reducing inflammation in the body can reduce risk of cardiovascular disease progression. And if you're interested in me going over some anti-inflammatory therapies, there's a bunch of them, as well as a few unconventional blood markers. So not looking at like C-reactive protein, for example, and looking at some other markers so that you can determine your own risk for yourself on your blood tests, then join the Physionic Insiders, and you will have access to the full version of this video. And hopefully, if you don't want to, and you'd like to just continue on with what we have here or just stay with what we have here, then thanks for watching. And I hope that you learned something, and I'll hope to speak with you in the near future. Have a good one. Bye.